So now we are going to study irreversible drugs. So in case of irreversible drugs, we have organophosphate, and we have carbamates. And inside organophosphates, we have ecothiophate, we have malathion, we have parathion, we have nerve gases. And in case of carbamates, we have aldicarb and carbaryl. So now we are going to see how they are used. Like ecothiophate is used in case of glaucoma. So these three drugs, we don't use them clinically, but they have high potential to cause poisoning. They are used as insecticides. So carbamates are also used for insecticides. So now we need to see once organophosphate poisoning occurs or carbamate poisoning occurs, what are the symptoms of that poisoning? So here we can say symptoms of organophosphate poisoning or carbamate poisoning. So the first symptom is meiosis. We say pinpoint pupil. Pupil is highly constricted, so it looks like as pinpoint. We have lacrimation, we have sweating, we have increased GIT movement, we have increased micturition, so these all are the symptoms of organophosphate poisoning. So once it occurs, so now we need an antidote. We need a drug that can oppose organophosphate poisoning or carbamate poisoning. So the drug which we use as antidote for both, whether it is organophosphate poisoning or whether it is carbamate poisoning. Antidote drug. It is atropine. So we can use this for both as organophosphate as well as carbamates. We have another drugs that can stimulate acetylcholine esterase inhibitor. Because actually, in case of organophosphate poisoning, they inhibit this enzyme. So now if we activate it, the poisoning slows down. So here we can use pralidoxime, or we can use diacetyl monoxime. But these two drugs, they can only be used for organophosphate poisoning. Not for carbamate poisoning. So we say that oximes, they work only for organophosphate poisoning. They don't work for carbamate poisoning. So now we are going to see what is the reason why they only work for organophosphate poisoning. See, here we have acetylcholine esterase. It has two sites, one anionic site and another asterisk site. Here also it has anionic site and asterisk site. So when organophosphate comes, it binds only asterisk site. We have pre-anionic site. But when carbamate comes, it binds both sides. So here there is no space on which oxime can bind. So this is the reason why oximes work only for organophosphates, not for carbamate poisoning. So now we will study non-selective muscarinic blockers. So either they can block M1, M2, M3, M4 or M5. We have two drugs here. One is atropine and another is hyoscine. So first of all we will see hyoscine. So hyoscine is a CNS depressant. It is also used in case of motion sickness. Don't confuse motion sickness with the mountain sickness, because motion sickness is a disease which is caused by motion, which stimulates vestibular apparatus. Which stimulates chemo trigger zone, and finally vomiting occurs. But motion sickness is different from mountain sickness. See, mountain sickness usually occurs when we travel mountains with higher altitude, like we have in Leh or Ladakh. So in case of mountain sickness, we have less partial pressure of oxygen, which can lead to hypoxia. And finally, it leads to respiratory problems. Sorry, the drug for mountain sickness is not oxymetazoline, but it is acetazolamide, which is carbonic anhydrase inhibitor. So this is the difference between motion sickness and mountain sickness. So this was all about hyoscine. So now we will see uses of atropine. So atropine is CNS stimulant. So in case of eye, atropine causes mydriasis and cycloplegia. As we know that mydriasis means dilation of pupil, and cycloplegia means weakness of ciliary muscles. See, like here we have retina, we have lens, we have ciliary muscles, we have cornea, so it's our pupil, and here we have image. See, if the pupil is constricted, like if pupil is constricted, so we can see only this part of retina. But if the pupil is dilated, like I can see this much, so we can see this much part of retina. So that's why During fundoscopy, we use atropine as a drug in order to see large portion of retina. So atropine, it leads to weakness of ciliary muscles, which can cause loss of accommodation. So atropine is used in those patients who have problem in accommodating the image. So we check which power of lens is useful for them. So we use atropine for them.
In case of heart,
Initially, atropine causes bradycardia. But finally, it leads to tachycardia. So in case of GIT, atropine decreases mortality. And at last we will discuss mushroom poisoning. We have three types of mushroom poisoning. We have early mushroom poisoning, we have delayed mushroom poisoning, mushroom poisoning because of Amanita muscaria. So early mushroom poisoning is seen in Inocybe species. Here the symptoms are because of increased cholinergic activity. Increased cholinergic activity. So atropine is given as antidote. Because we know atropine is anti-parasympathetic drug, or we can say it is parasympatholytic drug. After that we have delayed mushroom poisoning. The symptoms in case of delayed mushroom poisoning, they are not seen because of increased cholinergic activity. They are not seen because of increased cholinergic activity. Rather, they are seen by inhibiting mRNA synthesis. So here penicillin is given as drug. And last one we have mushroom poisoning because of Amanita muscaria. So here also the symptoms are not seen because of cholinergic activity. Rather they are seen because of stimulation of inhibitory and excitatory neurotransmitters. So here also atropine is not given as drug, but we give benzodiazepines. So by this way we completed parasympathetic nervous system.